Okay. Welcome to the Global Justice Report, an online production of the Center for Global Justice. I'm Roberto Robles, your host for today's program. The Center for Global Justice, El Centro para la Justicia Global, is a multinational and bilingual research center located in San Miguel de Allende, Mexico. The center is devoted to research and learning for a better world and empowering the solidarity economy. As you already noticed, this is a hybrid form event combining an in-person and online webinar. In the next sessions, the next webinars, for those out of town, you can participate online at our website, www.globaljusticecenter.org. And a final word related to financial concerns is that the Center for Global Justice depends on your donations to support these live webinars. You can donate at our website, www.globaljusticecenter.org. Dr. Haywood Hall, to my right, is the founder and director of PACE MD, which stands for Pan American Collaborative Emergency Development Program, a program initiated in San Miguel de Allende in 2002, which has trained over 50,000 health practitioners in Mexico, created a new standard in public access defibrillation, as well as in community-based training and competency certification in Mexico and Latin America. Dr. Hall is an Ashoka Social Impact Fellow, as well as internationally recognized emergency medicine physician who helped found the global emergency medicine subspecialty. So it's an honor for us to have you, Dr. Haywood.
Well, thank you very much. The topic says it's emergency medicine training, and I like to see this in a much broader, or presented in a much broader context, because that sounds very specialized, right? I mean, what does that have to do with most people? And it is a very important topic. Let's see, let me get this shared correctly. 1 second. Share. Okay. So over time, I've really switched from emergency medical training to emergency care, because that's a much broader thing. We've also aligned it more with community health in general, so there has to be a kind of a more reasonable, broader context, I should say. But this will give you an idea of our story. It really doesn't include everything. I mean, I could probably go on for a couple hours, and you don't want to do that. But I'll try to hit the highlights of this, right? So yeah, as mentioned, I'm an emergency medicine specialist. I was trained in the United States. I lived in Mexico when I was a child. I lived here for 8 years, and obviously I missed it the whole time that I was growing up in the United States, and found my way, became a specialist in emergency care. And then I said, okay, now what am I supposed to do? And I wound up just coming to Mexico and seeing what I could do to help. And somehow I became designated as one of the founders of a subspecialty, global emergency medicine. It was a shock to me. I came down from New Mexico, was where I was training, and where I trained, and I ran into a car accident on the way. This is the Camino Real that's actually comes right straight through San Miguel, goes all the way up to Albuquerque and Santa Fe, and it's I-25 in the United States. But anyway, there was an accident in the Sonoran Desert, and I stopped. It was the middle of the night, and when ambulance finally came, and I wound up having to decompress someone's chest, and there was a whole bunch of stuff that was going on there, and I came away feeling like there needed to be more training. And you know, I had a big adrenaline rush doing all that in the middle of nowhere. And then I continued my vacation and wound up in San Miguel in Guanajuato, which was another, just became a life-changing thing. I said, okay, I get it. I'm supposed to start a training program here. And so that's, the story is much longer, but that's kind of the story. Okay. So I started working with the health ministry to help them with their ambulance services. And then students started calling me from the United States, said they wanted to come help with our projects and could they learn Spanish? And I thought, oh, let's start a medical Spanish school. So we started medical Spanish back then in 2002, along with the PACE program formally. And we've had quite a few people. I'm guessing around 700 people in the Med Spanish program. And they've, you know, that's a way where there's been exchange of ideas. You know, they obviously have learned Spanish. There's 50 million Spanish speakers in the United States, so it's an essential medical skill. They have occasionally brought some really fantastic programs that we've translated and made work in Mexico, and I'll show you some of that. So it's been a very good collaboration and a good way of bringing some resources into the program. I have a timeline here, and I'm just going to go quickly so you can see all the kinds of stuff we did. I mean, really, like I said, this could take quite a while, but it gives you an idea of kind of the various activities we've been involved in. I'll drill down on some of them. But so there's a really big timeline here. We've done a lot of stuff. It's kind of shocking. So this is not quite up to date current, but you know, it's still significant. You know, there's 2.3 million neonates die within the first month of life in the world. You know, almost 300,000 or 250,000 women die from complications of childbirth, and 500,000 die from diarrheal illnesses, children. You know. Okay, I'm going to say the actual numbers are probably about 80% of that now. So there's been maybe some progress, but still, these are things that shouldn't be happening. I mean, these are things that are all treatable. And even like maternal death rates, interestingly, in the United States are shockingly high compared to other developed countries. And within the United States, within certain populations, it's absurdly high. You know, like it says here, Black women have 3 or 4 times the death rate, maternal death rate of white women. This is also not completely up to date, but the basic principles are all still there. What you have is a graph showing the life expectancy. It's, you know, starting at 81, trickling all the way down to the mid 70s, and then you can see how much per capita is spent on healthcare. And the point here is that there's absolutely no relationship between the amount of spending and the outcome. You know, we like to talk about evidence-based medicine, and it's like, well, there's no cause and effect here. Now, of course, I'm not saying we shouldn't be spending money on these things, but there's obviously something else going on. And interestingly, Cuba and the United States have basically the same life expectancy, and Cuba spends very little, and we spend very much. You know, so there's a lot of things going on, right? I'm just showing you some of the things that have kind of been in my mind that have triggered some of my thoughts on stuff. But this is something I saw in Oaxaca, which had the highest maternal mortality rate in the country for a while. And these are the distances that women would travel with postpartum hemorrhage. Now you can't go 12 hours postpartum hemorrhage without dying, you know. And the problem here is that everybody thought they needed to send them to the reference hospital 12 hours away, because that's the people who could handle it. Of course, by the time they got there, it was too late, and an army of doctors couldn't have fixed it. So the issue here is how to train people more locally so they can at least do initial things that can stabilize. You probably noticed that in the United States, healthcare is not a right. In Mexico, it's a constitutional right. They may have challenges in how to implement it, but over time, I think that they've been doing pretty well. I've been watching them for 20 years, and the hospital, the general hospital, used to be here on Reloj, and they didn't have a lot of stuff, and now there's a lot more stuff. So I think that they've been making some progress. So what we do is these competency-based certifications. That's, there's the knowledge, of course, that they have to learn, the skills which they have to apply, and these are like workshops. And then the abilities is what comes with experience and sharing experience and wisdom and that kind of stuff. So, we have sort of answers to how to do all of these parts to make it work. We've done some interesting things too that happened in the background, like you can see it on the skills part. That's a vacuum suction device that can be used instead of forceps. The forceps are on the right there. So the forceps are pretty dangerous, actually, and especially in the wrong hands. And the vacuum device, obviously, you can see is got a lot of soft edges, and it's just not quite as dangerous. So we've trained about 20,000 people on how to use those. We've been in the training people in ultrasound business for a long time, since the very beginning. It's probably one of the first courses. And of course, the technology has changed over time, and now the ultrasound devices fit in people's pockets. So so we continue to teach that because it's revolutionizing healthcare. We've done a whole bunch of courses. There's different types of courses, right? I mean, I explained a little bit about the methodology. I mean, but there's trauma courses, cardiac courses. We've trained people in, we've developed a trauma nursing course for a while. We had to translate all that material and apply it so that we'd have instructors and faculty and all of those kinds of things. We're one of the three only National Association of EMT training centers for a good while. The American Heart Association, I can say we were the third one in the country, and we were by far the biggest. We're the ones who opened up American Heart training all over the country. We've trained somewhere around 20,000 people in those courses: advanced cardiac life support, basic life support, and advanced pediatric life support. This was a Department of Redundancy department slide, I guess, but at least you get a closer view of the suction device. And we use these mannequins for simulation. The other things I already mentioned, the ultrasound, helping babies breathe. We were typically among the first to really do any of these courses, and they take off and others start using them and doing them. And that's good. I mean, it's success when other people start doing the same kinds of things, right? And right now it doesn't want to switch, it's frozen. Our STAR course is the Advanced Life Support for Obstetrics. It was brought to us by one of the Med Spanish students. I saw the book that he had. He wanted to train people in Guatemala in this course. And, I drilled down on the course and I said, wow, this looks pretty impressive. I took it to the director of the hospital here, Dr. Ortega, and he said, Haywood, you need to bring this course to Mexico. And then he became Secretary of Health, and then we pushed this course through, and it really has become the gold standard in Mexico. And so we've trained over 20,000 people in that. Okay, just a minute. So I mentioned about mortality rates. The United States has the highest mortality rate, maternal mortality rate of all developing countries. The maternal mortality rate in Mississippi is 82. I mean, and in New Mexico it's 79. This is worse than half of the countries in the world. And there are places that have literally zero maternal mortality rate. I'm bringing this in because this happened a year ago with my grandson. He came and really had all kinds of complications at birth and wound up in the intensive care unit, but came out okay. So this is why we do this stuff, to make sure that we have good outcomes, right? So the course became a gold standard. Nobody had really used this kind of a course for emergency obstetrics before, and it became part of the federal strategy to decrease maternal mortality, and it kind of explains here some of the breakdown of this. It became actually federal policy to do these kinds of courses. And we train people at all levels. These are all directors of hospitals. We have to actually train directors, and then the healthcare providers, the specialists, the nurses, all the way to the technicians, all the way down to I don't want to say all the way down to, but including midwives. So the idea is to train the system, not just train an individual. And so these were the first, midwives that worked with us. Actually, we had this idea of a community obstetric life support course that we are actually starting to regenerate, and obstetric first responders and like. I want to show you this video. I hope this comes out because you'll like it. Okay, sorry. Okay, maybe you can hear me now. Yeah, so we're looking at these things in terms of community level impact, like I said, we're not just training individuals, we're training the community in some ways, right? It's going to let me. So some of our projects that fit into that, I mean, one of the things we did was a sexual assault nurse examiner project. In the United States, we have that program, and we brought experts from the United States and from Mexico, the top people who were involved in forensics, and looked over this program to see how it might apply in Mexico and what kinds of modifications might be, and of course, seeing what kinds of things they're doing in Mexico. We had a lot, it was a small meeting, but there were some very heavy-duty people there who were involved in this, including the Attorney General's office, both in Texas and here, and as well as the leadership of reproductive and gender equality for Mexico and others. And this was another one that I think was a huge impact. This is the first public access defibrillator in Latin America. It's in Jardín, and it started a whole wave of massive training, and other places started doing this, and it even became part of public policy, how these things are going to be managed. So we trained everybody, Tránsito, the police, and how to use these, and then on a yearly basis we started having these kind of celebrations of the defibrillator, sort of an unusual thing. But there'd be Zumba and all kinds of stuff. So it really started to blossom there for a while. And then it changed administration, and then whatever, so. And that concept we took to other places like Zihuatanejo and San Cristobal Las Casas. And so we did mass training, train people. It's not just medical people, we want to get the whole community involved. And the people that have worked with us in our programs have really created policy changes in different areas. These are government policies on how to manage different types of medical problems and whatnot. And there was even in the Senate, they had to deal with the issue of defibrillators and how it is, how many need to be there per 500 people, that kind of thing. So these things generate a lot of change. But the point is that this is all community. These are community activities. These are things that we want to be. We want to have a community focus for these things. Let's see. So another path that we took was in 2007, we decided that we were going to help bring basically all of Latin America into the International Federation of Emergency Medicine. So I got involved in identifying countries that had training programs in emergency care, getting them to become full members of the IFEM, and then promoting some of the conferences that are done with the IFEM. So we did these, there was a whole campaign really for about 10 years of recognizing, finding and recognizing countries that had these qualifications and saw emergency medicine as a specialty. And we had the first international symposium on resuscitation here in San Miguel in 2011. It actually was the first symposium for the IFEM anywhere in the world, and that was very successful. And then we started doing a series of other conferences. This was in Atlanta. This is with Muhammad Yunus, who won the Nobel Prize in 2006 for microfinancing. And so they asked us if we could organize the health part of this health technology and education thing, and we did this in Atlanta. And then we did a series of other programs, conferences, and leading up to, we finally got the ISEM, the International Congress of Emergency Medicine, into Mexico City, first in Latin America. So these things just grew and became quite big. In the process, we also started doing these forums, and they continued to have we continued to have conferences that had pretty big impact. I was shocked to see that 650,000 people had somehow seen this. But and these were world leaders in emergency medicine and in public health. This is the Undersecretary of Health talking to a lot of the people that are in our network, and Judith Tintinelli is really the leader of the specialty worldwide, and she's always been involved in helping us. You know, it's just a very high quality event. This is Judith Tintinelli with Sanjeev Arora, who has this ECHO program, which is what it holds a tremendous amount of promise. We've introduced it to Mexico. There's probably 25 or so places now in Mexico that are starting to use this on a reasonable scale. And it's telementoring, basically. So it's very good. I won't go into the details of how that works, but it's actually very, very good program. So then in 2019, we did another forum. In 2020, we had to go digital. But so every time we would do one of these forums, we have a whole community-based thing where we do community training and just bring the, you know, do CPR and whatever other things that get people involved. And so the third forum went completely digital because of COVID. And then that kind of took the steam out of COVID took the steam out of a lot of things. So we're sort of in another cycle where we're trying to recover, and there's some digital things, digital transformation issues that we're all dealing with, right? And those are opportunities too. So we're really planning to work more, in addition, work in those areas, because that's really where a lot of changes are going to take place. What we're really wanting to do now is to formalize a center. We've done all this stuff without having, you know, any real center up to now. We do have a space that we can utilize at Posadas Monjas, where we had our office there for a while, but we want to reestablish that office. And we've started a 501c3 in the United States to support PACE. We've never had that before. And we think that this can be a really a very good center for global health and sort of, you know, collaborations and with universities and others having a sort of a field office for global health activity. I think that San Miguel is a perfect place for us to work that through. And so we're looking for anybody who can help us with these things. This takes technical ability and even some finances, but I think that we have a very long track record of having done a lot of things, and now we just need to figure out the right container for it. And so this kind of place, basically, we would continue to attract medical Spanish students. We would still have places that we could connect to their universities and their programs, and we can develop programs that make sense in Mexico based on a lot of our experiences and on new things. So that's pretty much what I was going to talk about. Not all the babies look like little aliens, but that's, you know, little plastic aliens. This is my grandson. Thank you. You all pass. All right. This was in the town square of San Cristobal Las Casas. And I think that's it. That's the whole show. So that's it. We've done all this without really any external funding at all. We've managed to be very lucky in creating programs that have been able to generate funds, and often it's the government that buys these funds, these courses from us. But it's been sort of like on a knife's edge trying to keep things going, because for all these reasons, there was quite a while where they could not train anybody because of COVID, and that you know, really caused a lot of problems for us. So we want to like reconstitute everything and make everything kind of run on its own again. That's the idea.
Yes. I'd like to ask you a question if I can.
Yeah, sure.
I just moved here. And this is a geriatric community. And in the sense that I'm the young kid here. But I don't think there's anyone that is trained on CPR. And how important it is, doctor, to have someone that in the case of a dire emergency can run to
Mhm.
CPR and know how to do.
Yeah.
Rather than now, when I do this and do that, know how to get on the phone, who to call. Are you bilingual? For 911, accompany people to the emergency.
Yeah.
And that is one of the things that are so important that I don't own this place, but I think that in the future, it'd be a good idea to talk about the family that own to see if there could be some training.
Mhm.
I don't know if you do that kind of work or who.
Yeah, we've done a lot of training. I can't tell you how many people in San Miguel have been trained by us or by others who we've trained. I'm guessing somewhere around 10,000 people. So it's not, yeah, so, but that's again, one of the advantages of kind of having a center is that you can keep things rolling a bit more. If everything is just kind of scattered, it just doesn't really work as easily. But there's really I mean, CPR is just a part of this whole thing, right? And we've trained people at different levels so that there's this whole concept of a chain of survival and making sure that everybody understands the basic protocols. We probably trained about 100 people at the Red Cross in advanced cardiac life support. There's probably the EMTs here, the paramedics here are probably the best trained in the country. Yeah, and we've had a lot to do with that. We actually are the official trainer for the Red Cross at the state level for some of these courses. So we work indirectly a lot. But we have not worked directly with the expat community, frankly. That's not happened before. And so, again, the idea of having a center is trying to do that and other types of things that can be very helpful. There's a lot of possibilities for providing better care before somebody needs CPR. We don't want to wait till then.
I just said in the video that the distance between a house and a hospital is critical. And how many minutes for the ambulance to get here? How many falls do we have here? And maybe severe falls. And how long is it going to be before someone knows what to do? Because everybody wants to do good, but do good is not going to help somebody survive.
So that was an interesting thing about the defibrillators is because, a lot of people said, what are you doing? You're putting defibrillators in this town. They don't even have a cath lab and, all these other things. And the fact is that when you start doing stuff like that, all of a sudden other things start to matter, like response times, people start watching things a little bit more closely and then make sure that the right protocols are in place and people have some training, and it starts to push things along that way. Because when we started, nobody had a clue what that was. It was like a radical thing to drop out of the sky,
Work closely with some of the local physicians, because there are physicians that occasionally give these programs at the biblioteca about medical services, which if you're new to San Miguel, maybe you haven't attended them, but they talk about subjects like what to do in the case of emergency, what records you need to have ready at your house. You can't just go to a hospital without your credit card or some cash because they won't admit you. So they do try to prepare us. I just wonder if you've worked with like Maxwell or any of the others.
So there's a defibrillator at the biblioteca. We put that there. There's this kind of funny line between what is a public service and what's a business, right? And for the most part, we've stayed out of the direct medical practice stuff because we don't want to be endorsing this person or that. It's a kind of, we're trying to operate at a different level, but so I think you can see what I'm getting at. There's a commercial aspect for healthcare here it's much more than there even used to be. So, yeah.
Person.
yeah, it's yeah,
How their services, what their
Yeah.
specialties are.
right. Yeah, so we've avoided getting in the middle of that. But we're starting to get into telehealth issue. Telehealth can be very, I think, very useful in a lot of ways. And so we're looking at how to manage those kinds of programs. I've been doing telemedicine administration in the United States for about 10 years. So I've been doing that for a very long time. And there's a lot of things, probably at least half of it, that can be managed without even going to a doctor's office or an emergency department. And of course, there's information that can be critical, that can be, important to have or have access to, that can make a big difference. In an outright, full-scale emergency, then you just have, then everybody's response really has to be kind of the same. You need to, it should be a 911 thing that works and getting you to a reasonable hospital. I think that some of the hospitals are better equipped than others and some are better equipped for certain things than other things. And so I'm careful not to over endorse a hospital. I think that they need to be, my hope is that when people understand the training and certifications that are involved, that they will look at that when they think about what hospital to go to. I hear people say that the general hospital, they shouldn't do this or shouldn't go there or whatever. I'll tell you, if it was a major accident and I was losing blood, that's probably where I'd want to go. That's where the blood is. So there's things that are worth knowing a little bit, right? I mean, the private hospitals, unless things have changed in the last year, don't typically have a lot of blood, don't have blood available.
You're afraid of a long wait?
You would not, you wait a long time if you have something that you can wait for. If you now, and you hear people complaining about how long the wait is, it's like, yeah, but it's not first come, first serve, it's worst come, first serve. That's the way it is in any working hospital, so it's not like you're bleeding to death and you're going to be put in the back of the line. That doesn't make any sense at all, right? So, and the reason you're waiting is because you have something that can wait and other people don't. And people forget about that a lot. Obviously, the public hospital, there's, hundreds of people. So, so if you're coming for something that can be handled elsewhere, you probably should go elsewhere. But
you work somehow with the midwives program of CASA? Centro Adolescentes y Familia Niña?
We've worked with them in the Also program from the beginning. We've invited them. They've participated to some extent. I don't think that they have, I think the program has changed a bit in the last year or so. Right. And now we're working with the whole issue of professionalization of midwives at a national level. We just came from a workshop for a few days on how to better professionalize the midwives. And so we have a program that we're working on for that. And all the midwives would be welcome to participate in that.
When your program opened today, I was trying to read everything quickly. It said that you work in international medicine. For example, we are a geriatric community here for the most part, but a lot of us do have opportunities to travel internationally quite a lot. And for example, I'm going to East Africa in a month, and I would love to get consultation on what sort of health vaccinations or antimalarials that I should take. How could I get that from you or your organization?
Well, with, our telemedicine service, telehealth service is pending. It's really, we're pretty close to launching that. And that's a perfect example of something that you can
but at this moment, I couldn't get.
Well, we might be able to work something.
I just gave them, well, I'm willing to pay for private patient with someone who can advise. Yeah, I just came from New York where I have Medicare and, get a lot of healthcare there.
Yeah.
At New York University's hospital. But I had difficulty finding anyone who would advise me about travel.
I think the WHO has online.
Or I read online. It's not what I said.
Most countries, they don't need a lot of shots anymore, am I wrong? I mean, like malaria, we used to get it going to West Africa. Last time I didn't need it. So I don't know, somebody, my doctor said you don't need it, or, when you take a malaria pill that can make you sick. I don't know. It's difficult to find out really how countries like that.
Well,
But in Latin America, we don't need a lot.
there are, regional and country to country differences, you can't cast this incredibly wide net. I mean, people get dengue fever here and a bunch of other stuff. There's some basic immunizations that are reasonable to have. But I think it's a good idea to see. But the other part is, if you're taking medicines, knowing what you need to take with you, and if you can get those medicines. People travel and they wind up places where they can't get their medicines. That's probably a pretty common problem. And what can be substituted, for instance? Oh. Do it up? Okay. So I'm closing this now. It's over.
So you have people on the line?
Yeah. Does anybody has a question for doctor?
Well, I would just make a comment that a very good way to disseminate your information other than a Zoom program like this, which will reach a certain amount of people in San Miguel, is through the San Miguel Civil List. It has thousands and thousands of members, and I know you're looking for donations and to get this center set up. And many people or organizations who are seeking for such help use the San Miguel Civil List.
It seems like a busy place.
Well, it has a lot of trivia, but it also has access to a lot of people who have money to support this thing.
Well, that's good.
Okay, so I think that's it. So I would like to thank Dr. Haywood and to everyone today for an informative discussion. Thank you very much.
Thank you so much.